So a couple things happened there. One thing was that we started to teach you a bowline knot, and we switched in our mind to tying the knot that we usually tie, a square knot, right? A suture knot. And so that became confusing. That will happen to any individual who already knows how to do something. They say in tennis that you don't let somebody keep serving the wrong way, because if they practice the serve 7 times, you then are breaking muscle memory, which is what happened to us, right? Muscle memory took over and you start doing the wrong knot. And so when you teach them, you want to teach them the right way the first time instead of having to fix the wrong way, because that is ingrained and that is muscle memory, okay?
I think another example that came out is that we saw he had a slight variation on his technique. You have a different technique. I had one technique I got right and one I got wrong. You had a different technique that all got the same knot in the end. But when you're teaching, you have to teach with consistency. So as long as you're teaching your process, you should teach it the same way every time. And you should encourage your faculty to adopt a best practice. And they should all, this is a very challenging part of this, but they should all be teaching the same methodology.
So we're glad we picked something that you don't usually use, right? But think about it. If one person to your right taught you one way, one person to your left taught you a separate way, one person across the table taught you another way, you would not have a good way to tie that knot.
And I'll be honest, I tried to learn a really fancy way for this, and that's what I totally screwed up.
So then when you're done in teaching the procedure, we're just going to talk real quick about 3 things that should happen, and then we're going to go on to teaching just in time. So one of the things you should do is give feedback, and feedback in a procedure should be immediate, right? You should fix that because you don't want them to generate muscle memory. Second, it should be specific behavioral based. As you saw when you were doing it, I don't want your hand to go over. I want your hand to go under. It was moving it from one behavior to another behavior, and then an explanation of why, if you continue in that direction, you're not going to get what you want, right? So outcome oriented. If you do it this way, you're going to end up with a square knot. If you do it this way, you're going to end up with a bowline knot. So an explanation. You'll want to give that feedback immediately when they're doing the procedure, when we're teaching the procedure. The next thing is we should assess them. So Sally said facetiously, are we going to test them for competency? And absolutely we should be testing them for competency. You guys should know that coming down the line, lots of hospitals are now saying that residents cannot do procedures unsupervised unless they've been marked off as competent. And they're figuring out a way at my institution with EPIC to mark them as competent. So the nurse can actually go look and say, you're incompetent to do this without a attending present, so you can't do it.
You lack demonstrated competence.
You're incompetent, you lack competence, right. So you've got to come up with a formal assessment. In order to do a formal assessment, I'll argue at least two things to happen. One thing is that the learner performs the procedure without any help. Often when we're assessing somebody, when they start to get in trouble, what do? We help them out, right? We're like, hey, how about this? What about if you did this, right? And then we go, well, they got most of it. We really need to see what you can do when you're assessing competency. What can you do on your own without any help? And the second thing is the assessor needs to have a checklist that tells you exactly what you're looking at. Otherwise, what do? We watch them, and they get an outcome that's good, and we go, that was pretty good. But if we had a checklist in front of us, we'd be able to say, but you actually did push up against the teeth when you were intubating, or you put the scope down too far. There's lots of things that we would see if we had a checklist and we knew what we were doing. So in formal assessment, we really ought to do this.
And I think airway is a great example of that. If you watch the majority of airways where I work, and I'm guessing where a lot of you work, there are critical components that get missed, or we don't do them completely or properly, and we're still successful the majority of the time. But I record a lot of airways in our emergency department, and almost always at least one step gets missed along the way.
So, please.
Yes, a lot of this in terms of having to visualize it, we're talking them through and giving feedback. We're perfectly well in a SIM situation, but how does it work when there's a patient saying, how many of you
Yeah, absolutely. We're going to walk you through that next. Absolutely. Thanks for saying that. Just one last thing here is as you teach them, one thing you want to do is to have them become the teacher, right? When you become the teacher, that's when you recognize, you're encouraging them to teach the procedure, you're going to provide close oversight. But when you try to teach a procedure, you realize what it is you know and don't know about the procedure, right? And that will make all of the learners better. Now, you need to be there because you need to correct them when they do things wrong, like we were corrected, right? Because if we teach them wrong, right, they're still going to do it wrong. And we don't want propagation of mistakes. And that's what happens right now. We teach one person, they get relatively good at it, they get the procedure in, and what do? We let them go teach the interns. And what are they teaching the interns? All of the mistakes that they make.
But I think that's often a point we miss in the department is observing our teachers teaching, and I won't say that I'm perfect at that either, but watching someone instruct is vital to learning how to, or to knowing that your interns, your junior level residents are being taught appropriately. All right, so we're going to do a little switcheroo here, so that's got to, yep, from this side. We're going to demonstrate doing a similar procedure now on shift. And I think that just-in-time education has become a pretty popular thing. I work in the sim world. Using simulated mannequins and devices prior to doing the real procedure is important. And we're going to cover a specific topic, nasal intubation. And I think nasal intubation is a good model for this because rarely does a patient come in that needs to be intubated this instant nasally. Usually it's like that angioedema patient, somebody who's maybe had post-operative problems, somebody that where they're kind of holding their own, but you see the impending doom coming. So you have time to think about doing this nasal intubation prep before you do the procedure. So there are various ways that you can look at this and various ways that you can address it. And the first just-in-time teaching, which I think a lot of us do on a regular basis, is just verbalization. So you're like, hey, we're going to nasally intubate this patient. Let's just step outside of the room. And I'm going to say, how many of these have you done?
On a live patient, none.
Yeah, okay. So then I already know like, the baseline's not going to be great. So then I maybe have to pick my target a little bit. So I have to be aware of that as well. And one of the things I can ask you is when we go in the room, what is it that you need to have available? And so having my learners step through all the things that we want ready for us.
So what you're trying to do at this point is trying to determine where are they on the spectrum. Are they on a spectrum where they can do it relatively easily, or are they on a spectrum where I need to be involved? Or maybe this is the one that I'm going to teach them in the clinical realm. So as you were asking, how do we do this? You're trying to assess where am I at. And if they can't even gather the right equipment, you know they shouldn't be doing the procedure. If they start gathering advanced equipment, then you're sort of going, okay, maybe you have more experience here.
Yeah, if he doesn't know that we should have suction ready, then probably this nasal intubation isn't something that he should be doing right now. And this is all just an example of one method of just-in-time teaching. All right, then the other thing that we can do is just go online. And I think this is probably the easiest utilization of just-in-time teaching that we have in the emergency department. You're about to perform almost any procedure now. It's like, just go to YouTube and look at a video and spend 5 minutes before we go into the room looking at a video. All right?
We teach all of our residents, proceduresconsult.com is who we worked with through the medical school. And so they read about it there, they watch videos there, and so just before they do a procedure, they can go back to some place they're very comfortable with and pull up a video, and they have very short videos that will show you how to do it so that they can get it back in their head.
Now, if you, for whatever reason, don't have access or time to look online on a video, just having them mentally go through the process and then verbalizing that back to you can have a very close approximation to that. At the very least, you might recognize a big learner gap that's present that you didn't think would be a problem for the learner. I just recently, I have one of my chief residents in the room, so I can speak freely, I think, right? I just recently had one of our upper level residents do a procedure with me and just had a huge glaring problem with placing a chest tube. And I could not believe how basic the problem was, and the fact that one of my mid-level residents was having this issue. Never would have guessed it going into the procedure. Really wish we would have talked about it ahead of time, because I made assumptions about my learner and I didn't ask them to kind of go through the process with me ahead of time. So this is all just another form of just-in-time teaching. And then finally, if you have time to actually go over a procedure prior to having to do the procedure, that is a thing that you can do as well. And this is in our lounge and sim lab. And it's just a set of airway heads and mannequins. There's no reason not to take one of those and have it in proximity to the emergency department. Airway is kind of one of those critical procedures we do where we take a healthy patient who's holding their own for the moment at least, and we take away their ability to live, and if we don't put a tube in the right spot, they die. Kind of a big deal. So why don't we have these resources available to us prior to us going into the room and practicing? All right, so mannequins and task trainers are great. They help us just go through the process of muscle memory, especially with rare things like nasal intubations. You know, many residents might get a couple of true nasal intubations during their residency training. So just the process of kind of warming up the neuro network before you get started and learning a couple of techniques. Like for my residents, I think a big one is not remembering how to drive the scope. They forget, you know, if the scope's inverted or not and how they control the scope. So just to get those things out of the way before you go do it on a real person. All right. So now we're at the bedside and we're ready to talk to our patient.
Right, so we're going to alert the patient what's going on. You asked this question, how do I do this, right? So I alert the patient. We're going to be intubating you nasotracheally, right? So we're going to work together on this. And you're going to hear us talking. We're going to talk about what we find in your anatomy and what maneuvers we need to do. We're going to talk about how we go around certain pieces. You're going to hear us talking about the procedure all along. That is absolutely okay and should be expected. That way they know that when I'm talking with the resident, everything is okay. It's not going awry. They're expecting to hear me say stuff. They're expecting to hear the resident ask questions. And that question then is not, oh my God, I don't know what I'm doing. That question is, I've run into an issue. How do we want to solve this? Which we do in all procedures, right? We just don't have somebody next to us talking. So having that is fantastic. The second thing is...
And I think just to add to that, it's fair that the patient knows that they're in a teaching hospital and the person is learning while taking care of them. That's only fair to the patient, and that you're going to keep them safe in the process.
So then telling the learner. I think that the learner should know, and I tell them up front, expect that if you start to do something wrong, I'm going to stop you right then and there. I'm not going to let you continue to proceed in that direction. So you may feel my hands come over your hands to stop you from doing what you're going to do. You may have me say, let's restart this piece, right? Because they need to know that when I want them to stop, they need to stop. Have you ever been in a room, central line? One of my senior residents doing the central line, femoral central line, and started to go in at 90 degrees. I was like, oh, well, maybe we could aim a little bit different. So you're going to be really careful about where you are in that. But you're going to alert both the learner and the patient that you're going to be doing this. Then you've got to, do you want to keep going? Or?
No, we can move on to this. So as far as the guided supervised practice, I think this is a critical component and one that can be tough if you don't have a good competency system for us. Yeah, that's me being nasally intubated by one of my soon to graduates, or nasally scoped. The story behind that is we have a football game every year with the surgeons, and I got a cardiothoracic surgeon gave me a forearm to the throat during the football game, and I got pretty bad vocal cord edema. So I let one of the residents scope me in conference. And she was not competent, and I learned that only while the scope was in my nose. But the point, I think, is knowing your learners and knowing how successful they are in the scale of competence for a given procedure is really important. It can be really challenging, especially for those of us as we get further from the clinical side and more into the academic administrative side. You might not work with a particular resident for months before you're expected to then know about their skill level in central line or intubation. So you have to, I think, keep a short leash and lengthen it as you get to know them specifically and you know what critical points you have to participate in. And then comes the art of bedside teaching.
Right, so how do you do it? What I'll do is tell them to step in and correct a mistake and use terminology that makes it safe for them, right? So we have a safe word. Everybody has a safe word. Mine happens to be pineapple. That doesn't work in the clinical world, right? So I will say things like, to address this issue, which is what I did when he was going in at 90 degrees, right? I said, to address the issue of having to go around the corner, I would drop this down to 15 degrees. And I gently let his hands go down to 15 degrees, right? So I could do it during the procedure, and he knew that I would step in to do that. Another way to say it is some people do it this way, some people like to do it this way. Here's another option. When I run into difficulty putting the wire in, this is what I will try. Right? All of these things sound fine if I'm the patient. They don't make me worry in any way. And then advise them to not use words like oops. Right? So when you start to correct them, they go, oops, sorry, I didn't mean to do that. Right? Those are all good things for them not to say when we're doing the procedure, and instead for them to talk through.
And oops is probably the one that slips out the most readily.
Or sorry, right? Lots of people say sorry all the time when you correct them. Like, sorry, sorry, sorry. Hearing that think of that being replayed in your head as the patient. Sorry? What do you mean sorry? What do you mean sorry again? What is going on? Right? So you need to prep beforehand. But now I'm able to walk into a room and walk through with them. In fact, the residents have learned that if I'm watching them and they start to get in trouble, one of the things they will do is describe the trouble they're in and ask for another way to do it. Right? So they might say, I'm having trouble passing the wire. I'm having trouble getting around the corner in the throat. That's fine. It's okay to have trouble. It's okay to have an issue. We'll talk it through. Right? In these situations, these are the things I do. Please.
So, given the constraints on time, it sounds like what you're proposing would require you to watch the entire procedure. That's not always feasible if it's busy, like all our departments are busy. So how do you adjust this to say we can only have critical parts of the procedure? Or do you just assume that this is a brand new learner that you have to walk?
No, it's different steps along the way. And so, like we said before, you're going to make that decision knowing the learner. You're going to assess the learner before they walk in the room in many different ways. And then you're going to decide when do I need to be in there. So central lines, depending on where they are, we train them in a cadaver lab and on a mannequin. But when they're in the room, I'll come in the room, see how they've got things set up. I'll say, show me the IJ. And they'll show me the IJ with the ultrasound, right? And then I'll have a better feeling as to whether or not I need to stay there. I may watch them start the procedure, and then I'll come back in at key times, right? I may come back in and say, show me the wire on ultrasound.
And I think
it just depends on how comfortable I am. And some, I will be, just show me the IJ. They show me the IJ, I'm like, boy, the janitor could hit that. I've seen you put a central line in before. I'm out. Give me a yell if you need anything. And then I'll poke my head back in. And literally, it's just poking my head back in. I'll come up to the curtain, put my head in, and they'll look at me, and they'll nod, tell me it's okay, or they're done. They'll tell me where they are in the procedure, and I'll either step out. And sometimes I poke my head in, and they're like, and that's when they need me. And I'll come there, but it depends. If they're a brand new learner, and this is their first one, I'm in the room the whole time.
And I think at least in our setup, we're required to have at least one other person in the room. So that person can, we all have phones, they can just give us a ring like, call me when you're set up, call me when you look at the vessel, call me when you put the wire in. And those are 3 points that could be critical, and if any of them don't look right, then you're at the bedside and the person doesn't have to call you. And I think, I love that some people may do it that way. Here's another way, because that really doesn't tip off the patient as long as you say it the right way. And I think prepping your learner with a signal for when they are in trouble, because they may be in trouble and you don't recognize it.
So those were great thoughts. Any other thoughts or concerns about when you're trying to correct people on a procedure? Please.
Our institution just had set some specific guidelines for both when the attendee might need to be in the room, so like needle vessel, wiring vessel, that needs to be maybe like that attendee, and it changes throughout the academic year for our procedure. Most of our R2s do all the procedures in the department, so they have to be present for all central lines for the first 3 months or whatever. But later in the academic year, all R2s have had 20, 30 central lines, and there's a little bit more laxity. So creating institutional guidelines, I think, have helped standardize the amount of oversight.
It's perfect because they're expecting it, and you can blame the other guy.
Yeah.
Some other guy said that I wouldn't do this with you, but some other guy makes me do it with you, so I'm going to do it this time. Absolutely, that's great.
With some caution that unless you have a competency-based checklist that they have to be signed off on, you might still find that learner who's really struggling, but you don't know it. So just, be cognizant of that as well.
So you really should try that. We didn't do it here, but you really should try to write out a checklist for a procedure. Then do me a favor, watch a procedure and ask yourself, how'd they do? And then look at the checklist. I think you'll be surprised at all the things that they didn't do that you're like, oh, they could have done that. Because most procedures we can do haphazardly. Intubation. How many times have you seen an intubation where their head's still like this, it's not tilted back, the head of the bed is not up, they crank back, right? But they still get the ET tube in. That's because you could have thrown the ET tube across the room and it would have gone in the right hole. But they think that what they did was a correct way. It's not the final outcome that always tells them they're doing it right. And then they argue with me, right? I say, let's talk about how you did that intubation. Like, I got the tube. It's like, yeah, but let's talk about how you did it. No, I got the tube. What's wrong? What are you arguing with me about? I got the tube, right? And what I have to explain is you got the tube because it was an easy tube. If this was a more difficult tube, this maneuver would have helped you. This maneuver would have helped you. This maneuver would have helped you. Because I want to get them to where they can intubate the most difficult airway, not the easiest airway. You're starting to want to say, please.
Standard checklist that you recommend per procedure, or is there a website that has particular standard checklists? I mean, those of us who've been doing it a long time don't necessarily have a checklist in our mind. We do it sort of
Right, absolutely.
to go back and formally teach ourselves in a sense.
So I don't know of one area that has everything, but I know lots of areas that have some. So like Cord has plenty of sheets that go through procedural piece. If you send me an email, I'll be glad to send you mine because I have several. There have been a couple of 2-3 articles that have gone through a modified Ankoff technique to decide how to do a perfect procedure. One of them is ultrasound guided IJ is out there in the literature. So you can go to the literature and find some of them that way. And then the other thing is, like we were saying, everybody does it the same way. Maybe getting together a group of people who really like to do procedures and walk through it and model it after the other ones, and then everybody's doing it the same way. Procedure Consult does have some checklists. They aren't as detailed. They're not as detailed as I like them to be. It's definitely a start.
EMRA has, they're in the process of building multiple procedural checklists now. So EMRA's got good checklists to go through like the nitty gritty, minute details of RSI and things like that. So EMRA's a good resource as well. And you probably have a resident who's a member if you can't get access to them.
Right, and even using that on your shift and walking through everything that needs to be done, or allowing them to review it, right? I'll give it to them. I'll say, hey, here's what we're doing today. And they'll go through that sheet. And that's just memory. That's just muscle memory. And then when I check it off, I'm like, hey, remember? And I always, when I work with somebody, I always take the blame. We should have done better on that patient. We should have ordered the ABG. When we were doing that procedure, we shouldn't have put the needle in at 90 degrees because I'm ultimately responsible, right? And so I take that hit. I don't say, you did it wrong and you screwed up. And I'm like, hey, we punctured the back of the vessel because we did this and we need to do better next time. Go ahead.
So proposition is you have this checklist which either you or the department has agreed upon, specific to the learner. You go through that first, and then you have that in the procedure, and then you go back to the checklist again. Is that one way?
Depends on how I'm doing it. When I'm teaching them, they get it long before they come into the cadaver lab, and then I follow that checklist specifically. When I'm testing them, I follow that checklist specifically. When we're doing just-in-time teaching, I may hand them one and say, run that through in your mind, make sure you got all the steps down. And usually they'll be like, oh yeah, I was going to forget that one step, right? And then when I give them feedback afterwards, we'll go through that same checklist.
And if you have availability to record, especially airway, I record a lot of airways, like I said, recording an airway and then walking them through their successful intubation and then pointing out the 7 things that could have been done better it's really, they find it very useful. I get a lot of great feedback on doing that. And it just takes your iPhone, and we have a CMAC, so you can just record the CMAC, put them together, and the residents don't realize how many mistakes they're making because they still get the tube in the hole.
So I hope you've seen that we talked about preparation, conceptualization, visualization, verbalization when we said to do it in the cadaver lab or when you're teaching not on skills. You follow along the same line as you see when you're doing it in the clinical world. You may drop parts of them out, but they actually help you decide where is this person. So think about just-in-time teaching next time, just before they get in. Let them walk through it so that their muscle memory works out the same way. Any other questions or thoughts?
So, just out of curiosity, what are the best applications you found about videos and upload to teaching?
Say that again. I'm sorry, I missed that.
Compliant videos of procedural stuff and then maybe you found any
A good resource for them, you mean?
We're saying HIPAA compliant, so I don't pull up videos that I have made unless I'm making them in the cadaver lab and I make sure you can't tell who the person is.
Yeah, from my standpoint, I have patients sign waivers, so.
Oh, you mean if I'm videoing it while we're doing the procedure? Oh, okay, I'm sorry, my apologies. At my institution, if you come in and we're doing critical care on you, the thing they sign off on is that we will videotape all of our traumas, all of our critical cares, all of our procedures, and the videotape is going. So,
Yeah,
they know about that immediately. I just have to alert all traumas goes immediately. If it's critical care, it goes immediately. If I'm doing the procedure and I want the videotape on, I ask the secretary to start the videotape. It's part of their sign-in to the hospital.
Yeah, and we have the same thing, but then if it's for educational or QI purposes,
Right,
so if
exactly
you're going to utilize it on I can use it
Paper.
here freely, but if I'm going to put it out to the public, then I have to get,
Then
we have a secondary waiver.
Because I'm not using it for QA. But since I'm using it for QA, I'm able to do that immediately. And I bet you it's the same. If you videotape your traumas, it's almost exactly the same. Cool?
All right, do we want to take time for this?
No, we do not.
Okay.
We're at the end of our time.
If you want
Is
to
that
play
good?
at the scope later on, we can play at the scope later on.
All right, thanks, guys. Appreciate your time.